Good morning. Welcome to Palliative Care and Geriatrics Grand Rounds. I'm B.R. Dobbin, the course director, and it's my privilege to introduce today's speaker as we continue with our fellow Grand Round series. Dr. Kayla Wolofsky is originally from Toronto, Ontario, Canada. She received her medical degree from the University of Queensland in Brisbane, Australia, and completed her internal medicine residency at the Emory University of Atlanta. Her clinical interests revolve around palliative care and global health. She's interested in the clinical and policy aspects of palliative care for medically underserved populations around the world. She just returned from a month-long elective in Kampala, Uganda, where she provided palliative care in both urban and rural settings. Dr. Wolofsky has accepted a position with the University of Toronto, where she'll be working as a full-time inpatient palliative care physician at Toronto General Hospital starting this July. Please join me in welcoming Dr. Wolofsky.
Good morning, everybody. Thank you so much for that kind introduction. My name is Kayla Wolofsky. I'm one of the palliative care fellows here at Mass General Hospital. It is beyond a privilege to speak to you about a topic that I am just so passionate about. And in front of me are some of my colleagues, my mentors, and people who have now become my families and friends. So thank you so much for giving me this opportunity. Today I am talking to you about something I'm exceptionally passionate about. I will be talking to you about the changing landscape of HIV and palliative care. I have no disclosures or any relationships with any industries pertaining to this presentation. So what do I hope that you will get from this presentation? Overall, HIV has been prominent for around almost 40 years. There's an overall changing landscape. There's a change in the HIV epidemiology as it relates specifically to palliative care. So I want you to be able to recognize these changes. There are very specific challenges to working with people living with HIV, and I hope that you can recognize these challenges as well as identify specific palliative care needs in caring for people living with HIV. Lastly, I will go through various models of how do we actually integrate palliative care into the management of people living with HIV. So why is this topic important? I will recognize that as a subspecialty here at Mass General Hospital, we don't see people living with HIV or those people that are infected with HIV in our daily practice. So why is this important? Well, because of the advancement of antiretroviral therapy, people are living much longer. Because stigma has decreased, more people are being willing to getting tested. Therefore, when we look at overall states, but in specific here in Massachusetts, over the past 10 years, there's been an overall increase by almost 25% in the number of people living with HIV. This number is expected to increase by approximately 2% per year. So what does this mean for you? It means that it is very likely that in our practice, we will be likely to see patients that have HIV. Because of advancements in ART therapy, and because people are living better and longer, it's actually expected that the number of people living with HIV over the age of 50 is predicted to increase to about almost 7 million by the year of 2020. This is so important. We are used to patients that have HIV that are the younger population, but this is the population that is getting older. For me, I wanted to open my grand rounds with two different case presentations. I'd like to talk to you about two patients that impacted my career. They are from two very different countries and unfortunately had two very different outcomes. The first, one of the cases I will talk to you about is a patient that is very dear to me and actually influenced my trajectory in medicine. One patient will be from Atlanta, Georgia, where I did my internal medicine residency at Grady Memorial Hospital. The other patient is someone I met in Kampala, Uganda. So I want you to come on this journey with me. So we have Mr. FW. He's a 53-year-old male, he's a police officer. He was diagnosed at the age of 34 with HIV. He's married, has 4 children. He's actually reported his illness to his family, his friends, his social network. He's actually followed up very closely by the HIV palliative care clinic. He's adherent to his medications. He came to clinic with no overall complaints and was just there for follow-up. Case 2, we have Mr. OW. This was a very unfortunate case. He's a 40-year-old gentleman. He was diagnosed with AIDS, also at the young age of 31, was not on current treatment. He had a significant viral load and low CD4 count. Unfortunately, this gentleman was lost to follow-up. He occasionally followed up with his primary care provider, but unfortunately was not in regular care. He presented to the hospital in diffuse, extreme pain, secondary what we thought to be was due to his Kaposi sarcoma. For those that have not seen Kaposi sarcoma, this is an illustration on your left. It's a diffuse cancer that is associated with HIV/AIDS. Unfortunately, this gentleman died secondary to cryptococcal meningitis. As I go through my presentation, I want you to pause and reflect. If you notice that I did not tell you where each patient was from, I want you to think to yourself which patient was from the US and which was from Uganda. As I go through, think, why did Mr. FW thrive? Why did he do so well? And unfortunately, what could we have done as physicians and multidisciplinary practitioners to prevent the death of Mr. OW? So as I go through my presentation, I'm going to outline as I go. So let's first talk about the change in HIV epidemiology and the trajectory of the disease as it relates to palliative care. I firmly believe that to do well in the future, we need to understand the past. I know we are not all familiar with HIV and its history, so I thought it would be very important to go through this. HIV is actually thought to be around well before 1981. There's some cases that are expected to be thought in 1963. But in 1981, HIV and AIDS was first recognized as a disease. This actually is the very first article right here, rare cancer seen in 41 homosexuals. Previously very healthy gay males were suddenly coming down with pneumocystis pneumonia and Kaposi sarcoma, and these gentlemen were well. There seemed to be an outbreak, and it was within a very specific population. In 1982, it was first named GRID, and this was in the States. This acronym, unfortunately, stood for Gay-Related Immune Disease. In Uganda, this unknown disease was referred to as SLIM, and what that specifically referred to was the wasting syndrome that was seen with people with HIV. Later in September, it was renamed to what we now know as AIDS. Let's go through a couple years. Unfortunately, this was a very scary time. No one understood the disease. It was very unclear as to how it was transmitted. It was being associated with people with IV drug use, homosexuals, and unfortunately also within blood transfusions. Luckily, in 1987, they did come up with the very first drug, AZT, which was developed in mice that was approved for the treatment of HIV. This drug, it had many side effects. People had nausea, vomiting, diarrhea, significant pain. Every 4 hours, they were getting IV medications, and it barely extended life. The prevalence of HIV continued, and luckily in 1996, combination ARVs were developed. Between 1981 and 1996, hospice was quite prevalent, and this was where people with HIV and AIDS primarily got their care. So hospice was actually on the forefront of the HIV/AIDS pandemic. Luckily, as I mentioned, there was combination ARVs. Even though the prevalence of HIV increased, there was a decreased related number of deaths, and this was thankfully due to treatment. It was around this time that hospice was seen as redundant. It was no longer sure if HIV/AIDS was going to be a terminal disease, so hospice houses slowly closed. Around the year 2010 and 2012, Truvada, which we now know as known as PrEP, was developed. One of the most significant, and I personally feel one of the most historical times in the past 10 years was in 2016. The CDC officially declared that if you are undetectable, you are untransmittable. So therefore, HIV cannot be passed between partners if you're undetectable. This is such a historic moment and a message that I want to be spread. Now, over half of the population with HIV are living with ARTs. This is now a time where palliative care can have a role again in the management of people living with HIV. As I mentioned, in the 1980s, HIV truly was seen as a terminal disease. Unfortunately, if you got diagnosed, it was a death sentence. People were terrified. They knew their time was very short. The mean survival after diagnosis was approximately anywhere between 9 to 18 months. What I'd like to draw your attention to is throughout my presentation, you will notice that I have very actually carefully selected some black and white photos which are representative of the time in the 80s when the AIDS pandemic was prevalent. This photo I chose because this is David Kirby. He's a very well-known AIDS activist. He essentially, when he came out to his family, was asked to leave the home. When he was later diagnosed with HIV/AIDS and was given a lifespan of approximately a few months, he called his family and asked if he could come home. And they did welcome him home with open arms, and unfortunately he died a few weeks later. So during this AIDS epidemic in the pre-ART era, anyone who had HIV/AIDS primarily died of an AIDS-related illness, so approximately 90%. The majority of AIDS-defining illnesses were pneumocystis pneumonia, which we now know is PJP, progressive multifocal leukoencephalopathy, toxoplasmosis, CMV, and disseminated MAC. And as you can see, if you had an AIDS-defining illness and you weren't on treatment, your lifespan was likely to be less than 6 months. There's also some AIDS-defining cancers in which we're aware of, but one of the primary ones is Kaposi sarcoma. So as I mentioned, this was a very important time for palliative care and those that were involved in hospice houses. Hospice houses truly were the front line of the AIDS pandemic in the 80s and 90s. So why did they become so prevalent? Well, at this time, AIDS was essentially defined as a debilitating illness, which was fatal once you were diagnosed. Many different practitioners, whether it be physicians, nursing staff, people who drew blood draws, it was a scary time. We did not know how HIV was transmitted. So hospitals in general just did not feel equipped to manage patients with HIV/AIDS. There wasn't a place for them. So these hospice houses came into existence. Unfortunately, for many of these patients, they were asked to leave their family, their homes. They were expelled into the streets. They had nowhere to go. And hospice homes that were designated for HIV/AIDS patients opened their arms and took them in. Lastly, and unfortunately, insurance companies in general refused to pay for medical costs attributed to AIDS. Many of these hospice houses ran on grants, generous donations, but also patients did have to pay out of pocket anywhere between $400 to $1,000 per month. Thankfully, as we've talked about, and I'm so pleased to say, AIDS-related deaths have decreased dramatically since ARTs become available. As you can see here, as ART coverage has increased, the number of AIDS-related deaths have decreased. If you remember before, I said that there was approximately 90% of AIDS-related illnesses that caused a death in HIV/AIDS patients, and this has now gone down to 30%. Because of this time where there's been a change in the lifespan of someone with HIV, a lot of these hospice houses actually started to close. With all these treatment breakthroughs and reduced mortality, hospice houses were seen as redundant. People felt that hospitals could handle patients with HIV, and therefore all of these hospice houses that were designated for AIDS patients were closed. The very last one was in Chicago, and this is known as the Chicago House, and this was closed in 1999. ART truly has changed the trajectory of HIV infection from one that was known to be a terminal illness to a chronic condition. What this diagram shows you is that these years are from the time of diagnosis to time of death. And what I hope to show you is that HIV truly is going to be a chronic condition and one that we just live with. The average age of someone with HIV and life expectancy is now nearing those of people who are not infected. Because of this aging population, there has actually been shown to be an association of people living with HIV and premature aging. So what does that mean? Well, in general, those who have HIV will develop chronic conditions about 10 years earlier than our HIV negative patients. There's been multiple studies to try to better understand this phenomenon. There's one thought that this is just due to normal aging, but I truly do believe that a lot of this has to do with persistent immune dysfunction and inflammation. A lot of these ARTs, especially the older ones that some of our older patients are taking, were very toxic. So things like tenofovir cause renal disease. And because this population went through such a hard time, there are certain lifestyle factors that are associated. So things like smoking, drug, and alcohol misuse. Because this is a population that we can now say that we will see, these are people that have HIV and also chronic comorbidities that I would like you to be aware of. Multiple studies, because of this phenomenon of premature aging, have been looking at different diseases that we can expect to see in this population. This specific study, I thought, very nicely summed up when we compared non-AIDS related comorbidities to those that are, as you can see in blue, HIV negative, and those that have been living with HIV. In this particular study, it's shown that things like dyslipidemia, COPD, chronic kidney disease, and type 2 diabetes are going to be much more prevalent in this population. What I found very interesting in this study is that they did actually not find an association with coronary vascular disease. This is a topic of debate. There's multiple studies that show inconsistent data. However, other studies have shown that those with HIV are much more likely, and I've actually seen 2 times the risk of things like MIs. Now, because this is a palliative care group, I do think it is appropriate to talk about some of the risks associated between HIV infection and non-AIDS defining cancers. So if you recall, Kaposi sarcoma is specifically known to be AIDS defining. As this population ages, we are very likely to see more Hodgkin's lymphoma, anal cancer, head and neck cancers, and hepatocellular carcinoma. Interestingly, in this study, there was a protective effect of someone having HIV and prostate cancer, which I thought was very unusual. So these are the type of cancers that we can expect to see within this population. I'd like to move on now and talk about some of the specific challenges and specific palliative care needs in caring for people living with HIV. This patient, her name was Ellen. She had 3 boys. When she was first diagnosed, she felt that she had no hope, no survival. She got on new combination ARTs, and her lifespan, she was able to see her sons graduate. So what is the role? As palliative care physicians, how can we kind of integrate into the management and treatment of people with HIV? Because these people, especially those that are older, are going to have quite a number of different symptoms. We're going to be balancing the symptoms that are caused by HIV, the virus, the treatment, but also now the comorbidity and the cancers. This is still a population that is undergoing serious feelings of isolation and ongoing stigma. Because of the symptoms, because of the stigma, because of the feelings of isolation, their adherence is still quite low. This is somewhere where I believe personally as palliative care physicians, we can make a great impact. I also think we can reduce the suffering that has been associated with ART medications. There have been a few HIV palliative care clinics, and when reviewing the literature, these are the top 3 reasons as to why someone might be referred to a palliative care clinic. So end-stage AIDS with opportunistic infections, pain, and psychosocial end-of-life concerns. There are many symptoms reported by patients with HIV and AIDS. There's some of the top ones that I came across are 75% of these patients will experience pain. Many will have neurocognitive decline. I recognize that this is not a symptom, but this is something that I feel you really need to be aware of. Patients that have been on chronic ART have changes in their body image. They are very self-conscious. There's lots of feelings of isolation and stigma, overall lack of energy and sleep, and depression and memory. I'm going to focus on pain, neurocognitive decline, and change in body and of image. So I recognize that we expect that people with HIV will likely have pain due to opportunistic infections. But what I found really interesting in all of these studies that I've read, people living with HIV, they primarily experience neuropathic pain. Why is this? Well, there's thought to be three main factors, two of which I believe really truly do contribute, and that's the HIV virus related and HIV treatment related. The virus itself is known to cause significant amounts of inflammation that target the nerves, therefore leading to HIV neuropathy. In addition, many of the opportunistic infections also target the nerves. Unfortunately, HIV treatment, especially some of the older medications from the 80s and 90s, are known to cause neuropathic pain. Once someone with HIV or AIDS develops an oncological cancer, a lot of them will go on chemotherapies, which again can cause neuropathic pain. So I want you to understand, if someone with HIV comes to your clinic, really be thinking about neuropathic pain and the agents that we can use to treat that. This was a fascinating study that I found in the Journal of Pain. It was done in 1996. I know we all hear in our clinics that people always say that their pain is undertreated. But what I found absolutely fascinating about this study is they compared AIDS patients and cancer patients in the outpatient care setting and found that overall AIDS patients actually feel that they're inadequately treated. And this was significant when compared to cancer patients in their own outpatient setting. Why is this? What are some of the predictors of undertreatment of pain? I don't know if everyone's familiar with the PMI score, but essentially what that means is it relates someone how they grade their pain and if they're on the appropriate medications. Anything less than -2 or -3 means that they're undertreated. Means that they're expressing pain and they're not on adequate medication. So in this study, what are the factors that are associated with patients who are undertreated? Well, female gender, low education, but what I thought was most fascinating was those that have intravenous drug use. This is a population that makes us as practitioners very nervous to prescribe opioids to. Oh, apologize. This is a slide that I recognize is very overwhelming, and we always say, why put a slide in if it's overwhelming? What I will say is what I want to draw your attention to is as we see patients in our clinic, you do have to recognize that a lot of the medications that we do use to treat pain have significant interactions with ARVs. This is a time when I think we need to consult our pharmacy team. Of course, methadone has very significant interactions. I think it's just so important to bring this slide up. We all think about, improving pain for quality of life. Within this HIV population, one of the most important things and one of the key messages I really truly want you to come across with is that any kind of medication adherence and viral suppression improves quality of life significantly. And by treating pain, we improve medication adherence. This was shown in a study back in 2015, where they actually saw people who claimed that their pain was adequately managed had 62% better adherence than those that had pain that was not well managed. The next symptom I wanted to discuss is, unfortunately, people living with HIV are much more likely to have neurocognitive impairment even in the era of antiretroviral therapy. Again, this is seen about 10 years younger than our population that does not have HIV. As you can see, it's quite a wide spectrum. We go from people with HIV with no cognitive impairment, but then there is 52% of the population over the age of 50 that you will see that has some form of impairment. The majority are known as HIV asymptomatic. What that means is that they have two cognitive functions that are decreased, so whether it be recall or mathematical, but their day-to-day is not affected. Then we have mild neurocognitive disorder, where again, they've got mild impairment, but they're also affected a little bit in their day-to-day. And then more significantly, we have HIV-associated dementia. Sometimes you'll see this as referred to as HAND. And unfortunately, these are people who essentially have Alzheimer's at a very early age. This is, again, something I mentioned earlier. Why talk about body image in a section of my talk about symptoms? I felt that this was a proper place for this to be put because someone's body image can affect their quality of life. It is associated with depression, withdrawal, and self-esteem. A lot of the older antiretroviral therapies cause what is now known as lipodystrophy. What you'll see in these patients is they have facial wasting and also wasting in the calf muscles, but then the fat gets redistributed into almost what we know as a buffalo hump and also in central adiposity tissue. When people start to see this phenomenon, a lot of them will actually stop their ARTs. They're either or they will think about stopping their ARTs, or they'll just change their medications. This is just something that's really important for us to be able to name. So if someone comes into your clinic and they've got low self-esteem, or you see these features, this is something that we should just acknowledge is really difficult to go through. There are procedures through plastics that can include facial fillers, but unfortunately it's quite difficult to change the distribution of the fat. One thing that I do want to say is why this also is so significant is people feel that this makes them identifiable as HIV positive. It's really important to talk about stigma because it's something that we don't talk about. Stigma in HIV is still pregnant. This is essentially the prejudice, the discounting, discrediting, and discrimination directed at people perceived to have AIDS or HIV. It can also be directed towards their loved ones and their groups. We all know stigma in HIV has been prevalent from the beginning. Ryan White is such a significant and historical figure in the AIDS epidemic. This was a little boy at the age of 13 who acquired HIV/AIDS through contaminated blood products. He was hemophiliac. This poor boy was banned from school. Unfortunately, on April 1990, he did die of an AIDS-related illness at age 18. But as you can see, the stigma, he was banned from school. People did not want him there. They were scared. Stigma in HIV continues in the 21st century. Stigma is so much bigger than just, I don't know how to, I'm going to contract HIV. It's bigger than, I don't want to hug you. I'm scared of your, kissing you. There's so many different levels. It all begins at the bottom with social, political, and economic power. It can then go to structural violence and pre-existing stigma. People with HIV feel as though they are labeled and stereotyped. They are also feeling separated from the rest of society. One thing I thought was very interesting is that we think of discrimination as just towards each other, but a lot of the time people with HIV have self-imposed discrimination, individual, structural, and there's institutional. So when I think about someone with HIV and the stigmas that are compared to the uninfected people, we do have HIV infection. They also battle stigma associated with sexual orientation, gender identity, racism, and injection drug use. But now they will also be fighting the stigma of ageism. Again, this is an aging population. I wanted to speak about this, and I felt this really represented some of the care that I was privileged to see in Kampala, Uganda. While there, they do actually have very specific HIV palliative care clinics. What happens is someone will come to their clinic, they'll see their physician, they'll see a pharmacist, and they will also see a guidance counselor. At every visit, they will do an HIV stigma screening form. As you can see on the left here, this is actually in Lugandan, which is their native language, and thankfully someone translated it for me. This is a stigma form from one of our patients that I presented earlier on in the case. But the general consensus that I got from this stigma form is this patient in general does not necessarily feel like the people that are in his close relationships have stopped caring about him, but he still is very worried about disclosing his HIV status. I thought this was an excellent screening form and something that we could adopt in our practice. One thing that I thought was very unfortunate is unfortunately people living with HIV still feel stigma from their healthcare providers. This was a study back done in 2007. They asked various HIV patients how they felt that their healthcare providers felt towards them. And 20%, this is still a very significant amount, felt that their healthcare providers were uncomfortable treating them. They felt that they avoided them, and some even felt that they were refused to be served. Despite having a relationship with these providers for 6 months, this stigma and the perception of stigma still continued. So why is stigma so important? Well, these 4 points I feel like just highlight it overall. In general, stigma avoids people who avoid getting tested for HIV. They are much less likely to disclose their HIV status. They're likely to only get care later in the disease and ultimately will refuse to take HIV medications. In palliative care, we really do rely on our caregivers, our family members, of those of our patients. There's something known as stigma by association. What this means is that the public stigma are reacting to people that are associated with HIV. So for example, say I had HIV, stigma to association would be stigma towards my mother. So for example, she might be ashamed to disclose my HIV status. This is really important in our practice as it's very difficult for providers to provide effective bereavement support in these situations. Stigma is really important, especially in the isolation felt during the process of death and dying. This is a stage of disease that our patients already feel very isolated and alone. Imagine dying and nobody knows what you're dying from and you have no support. I thought this was such a powerful quote by Roy Griffin in Atlanta. In the midst of illness, rejection, isolation, and probably death, one of the darkness's hands reaching out, not friends, families, or lovers, but strangers. And what Roy was referring to was strangers of other people living with HIV. So why is this such a unique population for palliative care teams to take care of? There's social factors. So like I mentioned, a lot of people living with HIV, they're, again, hitting the ages of 50. A lot of their communities have also been diagnosed with HIV, and there's been multiple losses. So these are people who also have survivor's guilt. So they have lived out loud with their friends and family. Many of their family members are also infected, therefore there's fewer caregivers. And again, these are already marginalized communities. Some of the treatment factors, well, this is a really hard, in palliative care, we like to prognosticate, and it's really hard when new therapies are given on an annual basis. A lot of the medications used in people living with HIV are used for prophylaxis, suppression, and palliation. And lastly, we're managing a lot of patients in the setting of addiction. What are some of the patient factors? We're used to an older population. Those living with HIV are still young. So they're relatively young. There's a lot of isolation due to stigma. Unfortunately, this population has a lot of adherence issues. And because we're living in a constantly changing time of advancing era of HAART treatment, reasonably, a lot of patients are denying death and advancing disease. There's obviously lots of disease factors. HIV is something that we are continually trying to better understand. It's very unpredictable, it's difficult to prognosticate, and there's honestly very rapidly changing knowledge. So lastly, I'd like to describe some of the models of how we can integrate palliative care into those living with HIV. We all know this slide very well. It's the continuum of palliative care in HIV. We start with the diagnosis. And one thing I really want to highlight is ART and palliative care really truly go hand in hand. They don't need to be one or the other. So what are some of the proposed care models in HIV and palliative care? Well, we have the inpatient service, and this can be as easy as if someone comes in with HIV, the the primary care service or the infectious disease team should consult palliative care. We can be there as an added layer of support and effectively address pain and other symptoms. In an outpatient service, some of the models I've seen, especially at Grady Memorial Hospital where I did my internal medicine residency, what can happen is patients with HIV can come to the palliative care clinic. Their first visit is usually longer, from an hour to an hour and a half, and they get 10 minutes to 15 minutes with each of these different disciplines: a nurse practitioner, a physician, a social worker, a chaplain, a pharmacist, and an outreach worker. The big picture being is that we ultimately want to provide symptom relief, retain them in care, and most importantly, if we can get viral suppression through ART adherence, we can likely enhance their quality of life. I found this really fascinating, and I didn't know, so I wanted to share it with this group. Massachusetts General Hospital has an HIV multidisciplinary team. Specifically, and pardon me, I'm not sure if this is going to come out Canadian, ZPAR, the Z meaning HIV, patients at risk. This is a wonderful team, and it's actually fairly new. It only came out in 2016. What happens is when patients come into hospital and they're HIV positive, either newly diagnosed or with symptoms, this team will send a representative to introduce themselves in the inpatient setting. They will get a warm handoff to the outpatient team, and then they will follow up on COX-5. This is actually shown a 90% in retention and care. So be aware that we actually do have a multidisciplinary team in Massachusetts General Hospital that manages patients. An area where I believe that palliative care can be helpful, again, is with pain management, goals of care, and advanced care planning. As we move through the continuum of palliative care and HIV, we, of course, have to talk about hospice care. There recently was an index that was developed called the Veterans Aging Cohort Study, in which looked at veterans, about 300, and they were able to develop an index that predicted 5-year mortality in people living with HIV on antiretroviral therapy. This index contains HIV-related factors and organ system factors, so things like CD4 count, viral load, hemoglobin, liver, and kidney function. As you can see on the left here, these are the different points that will be assigned, and you can find this calculator online. The max score you can get is 164, and of course the best is 0. But as you can see, as your score goes up, there's an increase in chance of mortality over the next 5 years. Using this calculator, they developed criteria for estimating a 6-month prognosis and hospice eligibility in patients living with HIV. So the first criteria is CD4 count of less than 25 or a viral load greater than 100,000. In addition to lymphoma, wasting, so again, loss of body weight, infection, various cancers, renal failure, and MAC. Next, they should have a decreased Karnofsky performance scale of less than 50%. And additional documentation of any of the following will support hospice eligibility. So this, between the Veterans Index and these criteria, this can help you decide if someone with HIV/AIDS is eligible for hospice. One of the big questions we come across in palliative care is which medications do we continue? Should we continue advanced retroviral therapy in hospice? Well, there's both benefits and disadvantages to continuing. The benefits of continuing ART is that it suppresses viral load. Again, the intent is not cure, but by controlling viral load, we're controlling symptoms. We're also going to sustain cognitive function, and will prevent IRIS, which is immune reconstitution. Some of the disadvantages is, unfortunately, ARTs, as I've discussed, have many side effects. It is a pill burden, and sometimes is confused goals of care. And again, some hospices will not pay for these medications. So kind of to start to summarize my presentation, does palliative care service improve medication adherence and quality of life? Well, when we looked at patients who actually went to palliative care with HIV, we did really well in care decision planning, addressing pain, as you can see. They were almost fully resolved. Nausea and vomiting, and constipation. Areas that we can do better include a lot of the mental health illnesses, so psychosocial, depression, anxiety, agitation, confusion, and hallucination. So these are areas that we can improve. One of the most fascinating things, and the message that I want you to leave this presentation with, is even though, so this team was in South Africa, it's called the Early ART Care Team, but as you can see, it's multidisciplinary. There's an HIV counselor, a psychologist, a social worker, a nurse, physician. They identify needs for palliative care. So again, this is a multidisciplinary team. And by involving them in the management of patients with HIV, you can see that they decrease the viral load by 94% and improve CD4 count by 300%. You can't argue that these numbers are not significant. So let's go back to our cases. I'm going to remind you, our case number 1 was Mr. FW. This is a gentleman that was doing exceptionally well. He is from Kampala, Uganda. My case 2, this was Mr. OW. He is a gentleman that died of cryptococcal meningitis, and he was from Atlanta, Georgia. And just quickly briefing, touching upon why did Mr. FW do so well? I truly believe that he did very well because he had multidisciplinary care. He was involved with physicians, nurse practitioners, social workers, pharmacists. He had social support. That is so important. His family was aware. He had the support of his friends. He was adherent to his medications, and his symptoms were well managed. Unfortunately for Mr. OW, he was lost to follow-up. He wasn't connected to a multidisciplinary team. He wasn't adherent, and his symptoms were just not well managed. And he was very isolated and very alone. So in conclusion, I really truly hope that this presentation has demonstrated to you that patients with HIV truly do benefit from palliative care services. The big picture being, if we can address symptoms, if we can address feelings of isolation and stigma and feeling alone, we truly can improve medication adherence, which therefore suppresses viral load and improves symptoms. We can improve the quality of life of people living with HIV. I'd like to thank many people. This is just a very small list, but my mentor, Dr. Mark Stoltenberg, our leadership, my wonderful co-fellows, but most importantly, the patient who, despite being at their most vulnerable time, share their story. Thank you.
Fantastic, Dr. Wolofsky, thank you. I want to open it up for questions or comments.
Thank you so much for that wonderful talk. I found it interesting how when you presented those two cases, I automatically assumed that the patient who was well was from Uganda and the patient who developed KS was, and the patient who was well was from the United States, but actually the reverse was true.
Yeah.
And so I wonder, I mean, that's really interesting because maybe that speaks to my own internal biases or my own internal prejudices. And I suppose reflecting on how I've interacted with patients, maybe as a physician, I've somehow worsened the feelings of stigma associated with HIV-related care. So I wonder what your thoughts are on that and how we can do better for these patients.
Yeah, thank you so much. That's a very thoughtful comment, and I appreciate you. So I do believe that why the patient in Uganda did so well is because HIV is just so prevalent there. The stigma still exists, but physicians, nurse practitioners, and social workers are very much familiar with their needs. And so they see this very regularly. The language they use and how open they are to talking about HIV, I believe makes people feel more comfortable to seeing physicians. I think what's so important is just naming things. So like I mentioned with the lipodystrophy and the stigma, if someone's feeling really isolated, saying, you know, does some of this isolation come from how you feel about how you look? and addressing things like the pain, and not always assuming that they have HIV because of intravenous drug use. And so kind of going more in depth and having more curiosity about why are they in pain, curiosity about why do you feel stigma, why do you feel that healthcare practitioners are not adequately addressing your pain. So I think with the HIV population particularly, just being really curious about who they are and setting aside the fact that they have HIV will just make you a better practitioner when it comes to treating these patients. Yes.
Do you think that some of it also may be from, in the Southeast, there's a lot of distrust towards the medical community, and I'm from Alabama. So when I went to medical school at South Alabama, I often heard from the patients, well, there was this sense that we were experimenting on them, that they felt like the medical system had failed them in a lot of ways, which they have reason to believe that. But I wonder if like that, some of the connection of why they may not come back, why there's not follow-up, is that just distrust, and how can we address that and make that better?
Yeah, absolutely. I completely agree with you. So one thing I did see when I was training at Emory was a lot of that distress. And that's actually such a big conversation in itself, you know, having goals of care conversation, advanced care planning. You know, it is a marginalized community down there, especially like socioeconomic status, primarily African Americans, a lot of a gay community. So I agree with you, there is a lot of distrust, and that could have been a big factor. How do we gain trust? I think it's always about being transparent. Transparency is so important. And again, naming things. So, you know, sometimes when we talk about advanced care planning, we should name why we are having this conversation. It's not because I think your time is short. It's just you are healthy now, so this is a good time for us to actually talk about the future. So naming about why we're having these conversations instead of allowing assumptions to happen. But I agree with you. I do believe a lot of the South, there is a lot of distrust within the medical system. And I will say that at Grady, they have a wonderful service, and that they do have a specialized immunization service there. So it's not that the care didn't exist there, but I thought for Mr. O.W., who I would like to say, and I wanted to dedicate this presentation to because he really impacted my career path. For him, it's about the access. He himself did not have the financial means to get to the hospital. So a lot of the time, you know, it was about 1 or 2 hours just to get to Grady. It was also the fact that he was isolated. He felt that his community wouldn't have accepted him. His family lived out in California, so he was very isolated. I am happy to say that when he was dying, he gave us the permission to give his diagnosis to his family, and his mother and sister actually were with him when he passed, and they were aware of his diagnosis.
Other questions or comments?
Good morning. Nice talk.
Thank you.
A comment and a question.
Of course.
The comment is, I was a medicine resident in 1981 and 1982, and it's hard to imagine what was happening at that time, because these young fellows were coming in with unimaginable, unrecognizable, fatal illnesses. And the desire to stigmatize them was quite strong. For a long time, there was a mnemonic of the 4 H's, which were hemophiliacs, heroin users, Haitians, really a bunch of 3 classes of undesirables in a lot of people's eyes, and then hemophiliacs. The question is, you were saying that patients with living with AIDS, with HIV, or have worse pain scores than patients living with cancer. And you were calling them undertreated, but you're not suggesting that they are needing more pain medicines. Maybe it seems that just increasing the doses of pain medicines on a population basis anyway has no effect on how people report pain scores. And then you were saying that people who had lower pain scores were more adherent. So if you say the treatment of pain is, once you're fixed on the narcotic doses, a lot of psychosocial help, then people who have higher pain scores might also be less likely to be adherent for psychosocial reasons, maybe. So
Absolutely.
I don't think, I hope you're not attributing causality to higher pain scores. You showed an association, but then sort of said maybe if we got better pain control, we'd have higher adherence. And I'm not sure that association supports a causal inference.
Right.
And then the last question is, you mentioned IVDU patients as being markedly undertreated compared to others, but couldn't a reasonable clinician try to not respond to every pain complaint of an IVDU patient who comes to see him?
Absolutely, and thank you so much. So what I'm trying to get across is that when compared to patients who have cancer, in general, it's felt that people who have HIV, their pain is not adequately well managed. The reason being, it's a little bit hard to understand the exact reason, and that's why I kind of brought in that slide with intravenous drug use. And when I talk about pain management, I'm not even just talking about opioids. A lot of the medications that were listed in these studies included NSAIDs, acetaminophen, gabapentin. Some did talk about opioids. And given that we know that neuropathic pain doesn't even respond very well to opioids, I'm more suggesting that we should be more likely to be thinking of medications like gabapentin. So when I talked about undertreatment, what I was referring to is that they leave visits feeling that their pain hasn't been adequately well managed. And again, with the intravenous drug use, I think that's just an association that was shown in this study. And again, my hope is that I'm not even trying to insinuate that we should be treating with opioids. I actually think that's not necessarily appropriate. If there's cancer-related pain, then absolutely. But a lot of this neuropathic pain, we should be using other agents and adjuvants.
I want to make sure we have time to open it up to any questions from our remote sites. Or any last questions here?
Kayla, that was just absolutely phenomenal, and thank you for tracing back the history of HIV. I too was a new nurse living in Atlanta when this virus came out and nobody knew what it was. And I just would like to, and all the things you pointed out, you brought me back to a time of being a very new nurse a long time ago. And I think about the suffering that these people had, not just physical, but all the other things that you had mentioned. And I can't help but make a parallel about the two cases that you presented and wonder about the socioeconomic status of them, their education. Mm-hmm. You mentioned that the access was very difficult. And when I was working in Atlanta, I was working at a private hospital initially, Piedmont, which was very affluent. Mm-hmm. And that's where we were seeing this disease that we didn't know what it was. And somewhere like Grady is public assistance hospital. So I just think that it still comes down to the basic demographics of people and how they're viewed and how they're treated. And honestly, it helped me realize how we can do a better job here in our institution. So thank you so much.
Thank you.
Well,